Good morning, everyone. My name's Robyn Gallagher. I'm chair of the International Council of Cardiovascular Prevention and Rehabilitation. And it's my absolute pleasure to begin this event. Gabriella, if you could go to the next slide, please. This webinar is part of a series that ICCPR is presenting to its member associations, friends, and to help support people in the delivery of cardiac rehab worldwide. And it's an absolute pleasure and quite humbling to be in the presence of so many wonderful clinicians and experts in cardiac rehab. In the map in front of you, you can see the 38 associations and 15 friends of ICCPR, and you can see that it covers a great deal of the world and includes several of our speakers who are presenting so ably for us today. Next slide, please, Gabriella. So the goal of this webinar is to learn and share information on how cardiac rehab programs have been adapting their practice and continuing the care of their patients. And we had a webinar this time last year to help support people in transferring cardiac rehab programs to virtual practice. So we thought it was timely for us to continue, given that COVID-19 and the pandemic restrictions are not going anywhere. But just to give you a heads up that we will be also doing another webinar on a slightly different topic in September. Thanks, Gabriella. To remind you that we have a great deal of resources available to help support cardiac rehab staff and patients, freely available on our website. And we encourage you to follow us on Twitter, where we provide lots of updates. Thanks, Gabriella. Just a reminder of how to ask questions. There are several ways. We'd prefer if you use the Q&A box to ask questions during the webinar. Now, we're not sure of how the timing will go today because we have people tuning in from across the world to present, and sometimes there can be a hitch in pickup, and as always. So we ask for your patience sometimes when these things occur, but if you could please use the Q&A for your question, and we guarantee that those questions will be answered. They may not be answered right today in the webinar, but we will ensure that we have follow-up and provide those answers to you. And a recording of the presentation will be available on the website. And if you could meet our speakers, we have Martin Heine, who I hope is online now, Dr. Marta Supervia, Professor Giuliano Gardenghi, I'm sorry, that's a little across my screen. Dr. Abraham Babu, Colin Yeung, and myself to finish off the webinar. I'm just going to check in with Gabriella now if Dr. Martin Heine is present. Okay, on the basis that what we will do is proceed. Sometimes these hitches happen, people can't tune in, Wi-Fi is not working in their locality. So Gabriella, I'm asking that you load up Dr. Marta Supervia's talk for me, and I'll introduce her. So Dr. Marta Supervia is from Spain. She's the Cardiac Rehab Program Director at the Department of Physical Medicine and Rehab at Gregorio Marañón General University Hospital, Madrid. And she will be talking in this video about ensuring patient safety in a center-based cardiac rehab during COVID-19. Thank you so much, Gabriella. Unfortunately, Gabriella, I am unable to hear that sound. I'm looking at Dr. Colin Yeung and asking if he can hear.
Hello, everyone. My name is Marta Supervia. And first of all, I would like to thank you for this opportunity to share our experience. I'm going to talk about how to ensure patient safety in a center cardiologization program at COVID-19 times. So in March 2020, we had to close our cardiologization program because of COVID-19. And before that, we were the biggest cardiologization program in Spain. We treat over 500 patients per year in our program, and we only offer a center-based cardiologization program. Before COVID-19 arrives, we talk about digital transformation, we talk about alternative cardiologization models, but then the COVID-19 arrives, and then we only had the phone to contact our cardiologization patients. According to the World Health Organization, almost 2/3 of countries stop the rehabilitation service, despite it is an essential service. So it was time to reinvent our cardiologization program. So we start to offer two kinds of models of cardiologization program. We opened our program in June 2020. So we start to offer the center-based cardiologization program with some changes. And we start to offer a non-center-based cardiologization program based on several sign appointments or phone call appointments with the patient. So the inclusion criteria that we follow to include the patients in one of the two cardiologization programs was the level of risk of getting COVID and had the worst prognosis. So at the beginning, we didn't include those patients with older age, but now that most of them are vaccinated, we are included them. At the beginning, we didn't include patients that had a transplant or any other immune system disease, or patients that had to use the public transport during a long time to come to the center. So to those patients, we start to offer the non-center-based cardiologization program. But we also consider the patient's preference. So some patients prefer to come to the center. So to those patients, we offer the non-center-based cardiologization program. We follow them through phone calls or some specific on-site appointments. We check the level of risk related to the cardiovascular disease. So those patients with low risk, we include them in the non-center-based cardiologization program. We follow them through several appointments. We check the number of cardiovascular risk factors or comorbidities, the functional status, and the willingness to change of the patients, because some patients had a lot of comorbidities, a lot of issues to solve, so they need more support from the healthcare providers. So those patients are included in the center-based cardiologization program. So why do we continue offering a center-based cardiologization program? Because we have a lack of resources to offer an alternative model through webcam or website. We consider the patient's preference, and most of the patients, they prefer to see to come to the center. Because we consider the benefits of group belongingness, and the average of our age of the people that they are coming to our center is around 60, 70. So they have kind of travel using technology. And because some of them, they need a physical exam, and they have a specific cardiovascular disease that they need more supervision. And because we have worked in our safety measure in order to make a safe center-based cardiologization program. In our current center-based cardiologization program, we ask the patient to sign the cardiologization consent, and the consent form is specific because of COVID-19. Then the patient has to inform to the cardiologization staff if they have fever, if they have had a close contact with someone with COVID-19 disease, if they have attended to a meeting with a lot of people. So we provide a contact phone number for all the patients that are coming to our center in order that they have a way to contact us and to let us know if they have any kind of issue. The patient has to follow some specific rules. They have to bring their own mask, they have to wash their hands, they have to bring as few personal belongings as possible, they have to be punctual, and so on. About the mask, it has been shown that in some studies that the use is safe. The only thing is that the performance can be affected, but in a very slight way. So before starting the cardiac rehabilitation program, the center-based cardiac rehabilitation program, we asked to the patient to get a COVID-19 test. Among those who were vaccinated, we don't, the test is not required. So this is because some studies has been shown that people that have been vaccinated, if they get infected with another kind of variant of the virus, the viral load is not going to be that high. They are supposed that they are not going to infect to the rest of the people. Anyway, we are checking on the day, every day, the publications, and we are checking with preventive medicines or protocol in order to update, depends on the evolution of the COVID-19 pandemic. Every time the patient comes to the center, we check the patient temperature, we ask to wash their hands, we ensure social distancing. The healthcare providers are well protected. Now we are all vaccinated. About the social distancing, we ensure that, but we have to reduce the number of patients in each session. At the beginning, we start with 4, and now we are treating in 7 in each group. About the quality of air, we ensure it through cross ventilation. We check CO2 levels, and always we are below 600 CO2 ppm. Usually we are around 500 or even lower. So, and about the material, we ask the patient to use their own elastic band, and after each group, the cleaner staff clean the treadmills and so on. We educate the patients about prevention measures of getting COVID-19. We have some videos about this. And when we do respiratory rehabilitation in cardiac rehabilitation patients, we follow the protocol of preventive medicine in order to clean the device. We use this when we are doing inspiratory muscle training in heart failure and after surgery. So in our current center-based cardiac rehabilitation program, we didn't have any kind of complications. We didn't have any kind of outbreak. We are increasing the number of patients in each group. And we are increasing the number of cardiac rehabilitation supervised sessions. About the quality of air, just to let you know that there are several protocols and documents around the world, depends on the country or region. So we ensure the quality of air through cross ventilation because we check the CO2 levels. If you can do that, you have to do a mechanical ventilation. And if you can ensure the quality, a good quality of air, you have to work on, you have to use a purifier. There is low risk of getting transmission by vomitus, and the main way of transmission is because the COVID-19 has redefined airborne transmission. So we have to work on safer indoor environments, and we have to improve the indoor ventilation and air quality for now and for the future. We motivate our patients to get vaccinated. And I would like to thank you all for attending to this talk, and I would like to thank to the science because of them we have a solution for this pandemic. Thank you so much, and if you have any doubt, any question, you can contact me through different social media or my email account. Thank you so much.
Thank you very much, Dr. Supervia. How informative that is to help us think about the need for vaccination and how we can manage to ensure we have clean air and we have better air quality, and all of the things that Marta has brought up will help us certainly with future outbreaks, flu, etc., and cross-contamination. So all very useful information. I would ask you to put questions in Q&A and we will ensure that those questions will be answered. We now have Dr. Martin Heine from South Africa, who will be talking. He's the research lead of management and prevention of chronic disease in low resource setting at the Institute of Sport and Exercise Medicine in South Africa. And he will be thinking about and expressing his thoughts on the global impact in the field of cardiac rehab, a helicopter overview of research conducted by ICCPR members. Welcome, Martin.
Hi, everyone. Apologies, I was a little bit late. I thought I had another hour still before the meeting started. I did the whole time converting thing, but apparently I didn't do it completely right. Yeah, so thanks to the council for giving me the opportunity to provide an overview of some of the cardiac rehab, or whether it's direct or indirectly related to cardiac rehab by council members. So just to give a little bit of a background how I got to this presentation. So I've been an ICCPR member since 2016, first on behalf of the South African Sports Medicine Association and later on behalf of ISM. And with the ICCPR, we meet quarterly, where we discuss the various topics. For me personally, some of the more important aspects were the cardiac rehab audit that we did, led by Professor Sherry Grace, as well as the current development of the cardiac rehab registry with a focus on low resource settings. Myself working mostly in low resource settings, that is of special interest. And if you look at, and this map is drawn from the Global Cardiac Rehab website, there are many different members and a lot of members of ICCPR, which is great. And I think this map even needs a little bit of updating still. And when we have these council meetings, the general invite to participate goes out to close to 140 different recipients. Yet when we have these council meetings, you see that there are specific voices that we actually would like to include in the conversations more often that don't seem to seep through in these conversations that we have during the council meetings. And I spoke to Prof Gallagher about this. And we suggested, so let's try and invite these members to at least for now share their research activities and see if we can get some of the activities highlighted of members that might not be so vocal during the meetings. So I've sent out an email to basically all the recipients with the ask to share some of their activities in relation to cardiac rehab, and specifically asked to not think around just the very rigorous research designs, the RCTs, but also like the smaller qualitative studies, the case study, the cohort study, like studies that might be very specific to a specific setting, but might be very interesting also for other low resource settings. And then I got myself a job because quite a number of countries members responded to this email, sharing, and this number actually needs to be updated still, close to 135 different articles, sometimes in lists and sometimes sending all the PDFs, which I needed to try to make sense of, sharing a little bit about what the global cardiac rehab community is doing. But it was nice to see that some of these voices that we don't hear too often, and we would like to hear more often during the council meetings, we're now also sharing some of their research activities. And these included, for instance, Indonesia, Korea, or South Korea, Bangladesh, Slovakia, and Greece. Then if we look at the income classifications, or the World Bank income classifications of where these members come from, then we still see that there is some revenue to gain in terms of input from low income or members in low income countries and lower middle income countries. But I was very chuffed with the response. So this is an overview of the countries that responded. So we had Brazil, Indonesia, China, Iran, Greece, Slovakia, the Netherlands, and the UK that shared some of their research activities. And South Korea and Bangladesh. Yeah, I think I got them all now. And I tried to sort of discern the broad focus of what these articles that were shared with me focused on, to give a little bit of a sense of what the focus is of some of our members. And I obviously can't say whether this is representative for the global cardiac rehab field, but just to give an indication. So the majority of studies were either related to cardiac rehab as a multimodal treatment model, or exercise specific. Then some of the other things that stood out, there was quite a number of studies related to the pathophysiology of cardiac conditions, the specific outcome measures that we can use in cardiac rehab or are specific for cardiac patients. And then obviously people also shared some of their COVID-related research, which I will now highlight specifically for this webinar. So now obviously I didn't do these studies, so I won't be going into too much depth in terms of what actually was done, but I just want to provide an overview of some of the activities that the members are engaging in. So these are the 9 studies that were shared with me specifically around COVID-19 research, and I've tried to color code them, and I'm going to leave this, I'll bring this slide back to you, but just to some of the trends that I would discern from these articles. So I picked 3 sort of themes that I feel like come through from these articles. The first being that there were some articles that focused on cardiac risk factors in relation to either acute COVID-19 outcomes or long COVID outcomes. Then it was interesting to see that there were some articles that specifically used basically the cross-fertilization between what we know as cardiopulmonary rehab and how that might inform rehab for COVID-19 patients. And then there were some articles that focused specifically around what can we learn from this pandemic, moving the cardiac rehab or cardiopulmonary rehab field forward. This pertained, for instance, towards the use of tele rehabilitation and those type of activities. Yeah, so this was basically my 10-minute overview of engaging with some of our members around what cardiac rehab research activities they engaged in, and I'm happy to answer any questions now or later. But I'll leave this slide for you up for now so that you can basically have a quick read and see if there's something interesting in there for you.
Thank you so much, Dr. Heine. One of the most important goals of ICCPR is that we serve our members and that we acknowledge our members' activities and the wonderful collaborations that can arise. So thank you so much for providing that summary. I'll remind everybody that we're going to use the Q&A for questions, and all questions will be answered, even if they're answered later and we contact our speakers at some other after the webinar. I'll now ask Professor Giulliano Gardenghi to speak. Dr. Gardenghi is a scientific coordinator for the Centre for Advanced Studies and Integrated Training, or CEAFI, and the chief editor of the Electronic Health and Science Journal. And he's going to provide us an update with what is happening in Brazil. Thank you so much, Giuliano. Giuliano on mute.
No, I'm not. Okay, it's a pleasure being here with you, Robyn, and everybody. It's a real honor for me from Brazil to talk about how the cardiovascular rehabilitation are going. And I will try in my 10 minutes to show you what is going on in here. That's why I'm here. I'm representing a Supervia, which is the huge cardiovascular rehabilitation entity from our country. And I thanks to them for the invitation also. Actually, I'm also representing all the services. I work in all of them, and I'm obliged to mention all of them. One thing that everybody is aware in the world is that the situation in Brazil is not that good. I got this graphic from the New York Times yesterday, and we can see that our situation here in Brazil, comparing the first wave with the second wave, is definitely worse, the worst one. And we are seeing now a slightly decrease in the cases, but this is not showing at the hospitals at the moment. I deal with 80 patients in the intensive care unit, and we see every day, some of them, a lot of them are dying, especially the intubated ones. We have a short in the sedatives, and we have a short in the assistance personnel also, and we are dealing with this fire every day in our rats. This we can see when we see the deaths in our country, and they are increasing in a huge way comparing the second wave with the first wave. And this is terrible for all of us. And we also have to consider this. When patients are dying, there are a lot of them who are surviving, and we are dealing with this in our rehabilitation associations now. We can see we have another problem with the vaccination. We have almost 6% of our country vaccinated by now, and we would like to have 60%. And we are far from that. I see that it is a problem all over the world, but we would like to see increasing, because our hope is the vaccine. As my colleague from Spain mentioned in her presentation, we are looking for that. So for us in the rehabilitation area, we have to deal with this problem, because with so low in the vaccines, we have to deal with patients who are at risk when they are showing for the rehabilitation process. Talking specifically about cardiovascular rehabilitation in Brazil, I've managed to create a presentation showing us some services from our country. I contacted some of them, and they provided me some information. I will talk about my service. I will talk about other one from a colleague of mine from Santa Catarina, another one from Bahia, Salvador, and another one from our capital, the Federal District from our country. First of all, we are going to talk about the cardiopulmonary clinic from Santa Catarina state, and the same pattern that we saw in the previous presentation. 6 months closed. You can imagine how to deal with the budget if you are supposed to remain closed for 6 months. It's terrible for everybody. Another thing is, after reopening, the decrease in the number of patients in 130, we are dealing from 12 to 4 patients, and also the impact on the revenue, and also the impact on the assistance itself. The cardiovascular assistance in our country is decreasing in this service. Also, we have to consider that we have to deal with a diminished revenue, and also with the increase of the costs, because we are dealing with proper personal equipment to protection. We have to deal with plastic film, alcohol to clear all the equipments all the time, before, during, and after the consultations. And we see a change in the assistance when they reopen it. After the reopening of the clinic, we see that the profile of the patients changed from cardiovascular and pulmonary rehabilitation to post-COVID rehabilitation. And this is 95% of the patients of the patients who are attending the clinic are from the COVID. And you can imagine in our country, as the pandemic is rolling out everybody, we are supposed to have these patients for us. These are them, Ju and Chris, who send me this data. The other steps that I'm supposed to represent here is Actus Cordius, and they mentioned the thing that is dealing with them in the northeast of our country. The first wave interrupted the treatment for 60% of their patients. 25 maintained the attendance of the clinic. They did not close in this clinic. And 50% went online. This was the first wave. When we are dealing with the second wave, only 30% of the pre-pandemic patients returned in a person. Then we are again dealing with the problem of the revenue and budget, and this is they had to close one of their clinics because of this. Nowadays they started to adapt. They started a home service, home care service, and increased it a little bit their assistance. They are reaching now 70% of the total patients that they attended at March 2020 because of the previous of the pandemic. Now we are dealing with this. They are almost slowly getting back on their feet to assistance. The third one is from our capital, Fit Cordis, and they show patterns very similar to the other one. 6 months closed. Also telerehabilitation with low adherence, not successful. And after opening, the adjustments were made to the environment, decreasing the number of patients seen per hour to 2. And you can imagine how to survive in a clinic with 2 patients per hour. It's not easy. When we see their data in a short view, we know in the beginning of the first wave, 81% is still attending. But as we see the coping measures and everything, they are closed. A little bit of online assistance, but not effective for the revenue thing. In October, they reopened with 44% of their previous patients, and they were able to increase it a little bit until now, 54%. But you can see the impact of that. And the telerehabilitation thing wasn't able to reach out from where we would like to be. And they are dealing with this also, suffering from the pandemic until now. When I talk about my service at the central region of the country, we closed the clinic from March to July, 5 months closed. Also, when we reopened it, slowly the patients were returning, but with a different profile also with my assistance. From October 20 until now, post-COVID patients are the majority of my patients at my clinic. 75% of them are post-COVID. And it's terrible when we consider the pandemic, but when we consider survival, it's important for us to have these patients coming until to a specialized service. When these patients are increasing, and this motivated me to open a second clinic. Is now on, and we are dealing with the long COVID haulers, and this is the images of the new clinic, and we are dealing with this in my region by now. Another thing that we are facing here in Brazil is that large rehabilitation centers are condemned. We are aware that joining everybody in a huge installation will not be possible in the next months or the next year. So these kind of structures are suffering now because I have some colleagues who opened a clinic like this and it's completely empty, and they are supposed to a lot of problems with money to sustain this, to pay their bills, and we are dealing with this. We can see this image of a lot of people, one on the side of the other running. This is unthinkable nowadays, huh? And we are changing gears for this kind of facilities where we have in studio few people. In this facility is the one that I'm guiding some of my patients now here in Goiânia, and we are dealing with this 2 or 3 patients at a time, but with a smaller structure, which is allowing us to deal with this in a financial way, in a different way, a huge turn in our practice, but it's what we are dealing now. This is what I'm doing actually nowadays. The home assistance is increasing also, and will continue to rise probably because we have a lot of colleagues who are able to do this. They are leaving their colleges now, and they are starting this kind of systems. But we have to consider some drawbacks. For example, lack of equipment for training progression. We would like to have more at home, and it's not easy. So the people who are dealing with this, our colleagues, are supposed to be creative to create some solutions at the systems. In a huge country like us, we have to reach some regions who are not easy to be reached. And this is a tendency in our country, the home-based rehabilitation, but personally, not in a tele-rehabilitation way. Some things that we are supposed to talk in a presentation like that is that our government is not worried about the cardiovascular or the post-COVID rehabilitation centers. We are dealing with a lot of unemployment, and this will impact us in the future because the money for the patients to come to the rehabilitation will not be easy for them to spare for us. Now, you know that we are dealing with this problem now. And when we talk about this, the situation is for crying, if you deal with me. When we see all the colleagues who provide me information, they said the same thing. From different rehabilitation centers. First, many patients who attained rehabilitation in the pre-pandemic era did not return. This is a fact. They are scared. When we talk to them, they are isolated and scared, especially the older ones. When we are dealing with this, the family sometimes does not allow them. They fear for their dear ones, and they say, no, you're supposed to stay at home. You are not supposed to re-engage your rehabilitation problem. So we don't have this easily coming back. Many moved to beach houses or the countryside. They are not in the mood of coming to the centers, to the capital, to the biggest cities, because there is a huge sense of contamination. There's a huge chance of contamination. They are not in this mood nowadays. Other thing is that the target audience of the rehabilitation has changed from cardiovascular and pulmonary patients to post-COVID patients. And this is a reality for our country. I guess everybody from Brazil who is here agrees with me on that. For the closure thing, my family took this picture yesterday when we were coming home, and I have this saying for youth now. I hope that at the end of this road, we can still be providing our services. May the light we see in this image illuminate us and end this pandemic. In time, photo taken by my family yesterday. I would like to thank everybody for your presence. It was a pleasure being here. Sorry for the speaking thing because it's not my native language, but I hope everybody could understand what I'm saying. It's a pleasure being here with you.
Thank you so much, Professor Gardenghi. Fascinating insight, and certainly lots of things for us to consider, including budget, facilities, and what patients will tolerate and how much they're interested in when they feel that they're at risk. So I'd like encourage everyone again to go to the Q&A and ask questions so that Professor Gardenghi can answer those, or either live later in the panel or by email later on. I'd now like to introduce Dr. Abraham Babu, who's from the Department of Physiotherapy at Manipal College of Health Professions in Manipal, India. Thank you so much, Dr. Babu.
Thank you, Robyn, and thanks to ICCPR for this opportunity to be here today and speak to you on what's happening in India, and are we better prepared to deliver cardiac rehab during this second wave. The fight for cardiac rehab in the pre-COVID era has been immense, and a lot of countries have been gaining momentum, especially in the low middle income countries. And the higher income countries were doing much better than us. But why was it that low middle income countries were not doing so well? This was some qualitative work which we had done just before COVID set in, and we're still writing it up. But we did identify quite a bit of challenges and inadequacies in our systems. And many of these may be similar across various low middle income countries as well. So in challenges at centers, in the hospitals and related to patients, and in inadequacies we find with regard to human resources management and care. But COVID came and hit us, and it brought everything to a grinding halt. And these are graphs that we've all seen. And just to show you that the Indian context, we did go past our first wave, and even though people call it the second wave, a lot of people here call it the next tsunami that's hitting us at this point in time. So what did we learn during the first wave? Well, what we did see was that cardiac rehab was interrupted in almost 90% of programs in India. And this was from the ICCPR survey of cardiac rehab programs during the COVID time. There were models that came up using technology, and we proposed a model known as the technology-driven cardiac rehab model, which allowed patients to either get into a home-based program or a technology-assisted or technology-driven cardiac rehab program. And these programs help you to focus on assessment, interventions, monitoring and follow-up for patients in their home. And obviously you go digital, you have exercise videos that can be shared, but also important that we consider those and those who do not have access to all this technology as well. And in that context, a simple phone call does just as well as a video call. Of course, we may not be able to do some of the monitoring or the assessments that we would like, but you could definitely look at involving patients and their caregivers into it. And of course, you could have teleconsults. So the first phase, the first wave actually did help us to a very great extent. The current scenario in India is quite bad, and these are graphs from yesterday. And these are just hotspots that show you all what's happening across the country. Now, if we were to intersperse these and look at how cardiac rehab centers could be affected, we had identified certain states and certain centers. The image on your left was from our publication from the Global Cardiac Rehab Survey, where we looked at just cardiac rehab in India. And if we look at the hotspots that we see where COVID is concentrated at present, they seem to also be in the same states which had cardiac rehab centers, which means there is going to be a significant impact in delivery of cardiac rehab services at this time. But if you were to look at it purely from a low middle income country perspective, has anything really changed? Pre-COVID, we know that we've had difficulty to access patients, limited manpower. Like my colleague said, cardiac rehab is a low priority. There are reimbursement challenges. But the good thing was that we've always been using home-based cardiac rehab because of difficulty for patients to come to the center. And we've always been using telephone calls to help guide the rehab program. During COVID, what has changed? Well, greater difficulty in access to patients, no doubt. Manpower remains the same. Cardiac rehab is still low priority. Reimbursement challenges are still there. And we are still using home-based cardiac rehab and a simple technology wherever it's possible. So I would only say that nothing much has changed, except that we are finding it harder to have access to patients. And going back to the qualitative work that we did in cardiac rehab, I'll intersperse it to show you the challenges and inadequacies in terms of COVID care. And many of you may have seen the news, which shows you some part of it, but overall, yes, we are struggling in infrastructure, accessibility, and the limited manpower that we have to take care of COVID patients. So I do see an overlap and some amount of parallel challenges and inadequacies in cardiac rehab and COVID care. So the challenges where health systems are strained is, what do you focus on? Both have similar challenges and inadequacies, but COVID probably takes over cardiac rehab. So what have we been doing at this point? Well, we continue to provide inpatient care, though we have limited staff and limited services. We continue to offer alternate models to those who reach us, and this is again home-based with telephone calls. We also use WhatsApp-supported exercise sessions, so we circulate videos of exercise. We monitor a lot of our high-risk patients through video calls, specifically those with pulmonary hypertension and heart failure. And we have also started looking at remote assessments through video supervised calls and involving patient and caregiver engagement. So the take-home message is that cardiac rehab can be provided through very simple means. Use the telephone or even the postal service. This is the time to work around the challenges and not to overcome them. It's important that we learn from our past experiences of the first wave, and most important, stay safe so that you can minister to others in need. Thank you for your attention.
Thank you so much, Dr. Babu. And I encourage people again to go to the Q&A to ask questions of Dr. Babu and all of our speakers so far. and we will ensure that those questions are answered. And thank you particularly to these speakers who have taken time out from very busy schedules and difficult times in their country. I'm now going to introduce Dr. Colin Yeung, who is a preventive cardiologist and assistant professor at the Department of Medicine, University of Saskatchewan, Canada. And he's going to be talking about a new toolkit, which is available to everybody, I believe, Colin. Thank you so much.
Is my screen visible?
No, Colin.
No, Colin, not to me.
You have to give me the sharing rights.
Gabriella?
I think you
Crystal?
have it because you're a panelist. Yeah.
Yeah, you do, you do.
Okay. Well, it's not giving me the ability to share.
Oh, could you, Crystal, would you mind checking?
Well, I'll just start by saying thanks for the ICCPR for inviting me to share about this toolkit that literally is 2 weeks old. It's just been released 2 weeks ago. So it's hot off the press, and hopefully we'll be able to get to my slides here.
Colin, Crystal just mentioned to me that you're listed as a co-host, so you should be able to share your screen. If you
Oh yeah, okay, here we go.
Okay, perfect. Perfect. Thank you.
All right, so
Thank you.
I'll try to be quick just to make up the time. So this is the symbol for the Heart and Stroke Foundation Canada. It's a not-for-profit organization. And I do have representation on the International Council and the ICCPR on the board and executive, but I'm also representing the CACPR, the Canadian Association of Cardiovascular Prevention and Rehabilitation. And this is a toolkit that's been designed just in the last year, and again, just released in the last 2 weeks. And it's called the Virtual Cardiovascular Prevention and Rehabilitation Implementation Toolkit. I am at the University of Saskatchewan here in Canada. So because of this pandemic, we're sort of forced to have a rapid transition to virtual care. And whether we like it or not, it's here to stay. We have to adapt and evolve. And unfortunately, while what I'm presenting is an example of what we have in Canada, it may not be applicable to all countries, especially low and middle income countries, but just as an idea as to what we have available in Canada. So it's really just a toolkit to help with the virtual care delivery in setting cardiac rehab. So just to go over some of the background, Heart and Stroke Foundation in Canada released an update last year, early in the pandemic, where this was an implementation toolkit for management of stroke. And so upon that release, additional feedback came and informed the Heart and Stroke Foundation that there was equally a need for the toolkit to support the delivery of cardiac rehab. And so subsequently, the Heart and Stroke Foundation collaborated with the CACPR and developed the cardiac rehabilitation version of that toolkit. And the purpose of the toolkit is to support and provide guidance on the delivery of virtual cardiovascular rehabilitation. So it's not just cardiac rehab, but now the term cardiovascular rehab is emerging, as well as secondary prevention via virtual modalities. And we've defined it as including teleconferencing, video conferencing, secure messaging, or audio digital tools. So not everyone has access to video conferencing, but it really does span a wide spectrum. And so the purpose of this document is to highlight areas and components of cardiovascular rehabilitation and secondary prevention that's to be modified for a virtual environment. And I want to stress that this is not a guideline document. We do not make recommendations. It really is just a toolkit to offer tips and tools to virtualize cardiac rehab. And so it offers considerations to support clinical judgment and establish local policies and procedures in the process. So in the development process, this virtual toolkit was developed using an iterative and consultative process, collaborating with the CACPR, and there are key stakeholder members of the CACPR that were involved, as well as an external group of multidisciplinary expert reviewers. And through regular group meetings, the writing group met between August and December virtually, and we had all the members on board in these meetings. And it went through an internal review process after we had developed the initial draft. And then it went out to an external review process with reviewers that were sought from multiple disciplines, as well as representation from every province across Canada. And I just want to acknowledge and thank you, our writing group members in this document, of which I was involved. Rebecca McGuff is the primary author, and then our senior corresponding author is Dr. Patrice Lindsay, who's the Director of Systems Change at the Heart and Stroke Foundation. But many of these names are involved in the Canadian Association of Cardiovascular Prevention and Rehab on the board of directors as well. So looking at the toolkit, it goes through an emulation, or basically virtualization of cardiac rehab. And we had two main sections, and you can see in the blue, it's broken down into infrastructure and technology is one section, and then clinical care in the yellow. So we had 6 elements in the infrastructure and technology. And if you follow along this course, it basically establishes that we want to have the structure to manage the schedule and the service appointments. We have to have the clinical capacity and expertise to offer this rehab. We have to have the technology and the support, and going along and just follow along this roadmap of the clients that go through cardiac rehab. We want to make sure that we have appropriate technology to monitor and measure. We have to have a mechanism to refer and manage the bookings. And again, alternate plans if any issues arise. And that's our infrastructure and technology section. But going into the clinical section, and this is usually what we would see in in-person cardiac rehab. And the start of the clinical section is really about risk management, the risks of going through this process. And then there's a preparation phase for the virtual sessions to allow the healthcare provider and the patient to be prepared. We talk about laboratory and diagnostic tests, the intake and initial assessment, and then going to the bottom row, we have considerations for group versus individual care delivery. We talk about contingency plans for medical management during the rehab sessions. And then there's the clinical care detailed in its subsections with management of risk factors, exercise, education, and medication management. Lastly, we talk about the ending of the virtual session and appropriate follow-up, and the maintenance phase and long-term management subsequently to the conclusion of the virtual rehab. We also make mention of the importance of data and registry and evaluation of this process. And so that might be a plug for our subsequent ICCPR registry, which will be mentioned, I'm sure, at some point in the future. But these are some screenshots of our toolkit. And this is really just what you would see is directly taken from our toolkit that you can access online. And you can see that we have the elements that I talked about in that map. And then you have 2 columns, the healthcare provider and then the individual family or caregiver. And these are issues that we found were important to those 2 parties. And so if you can see, there's sort of check boxes or elements within these columns. And I just highlighted the issues that might be pertinent to the individual undergoing the cardiac rehab or the individual's family members. So I won't go into this as we're short on time, but we did have the 6 elements under the infrastructure and technology. And these are just sort of examples and elements under the clinical care. Maybe I'll just go over this one just as examples. That's some elements that were taken out from the toolkit. For the healthcare provider and the intake and initial assessment, it talks about consent to continue with the session. We want to have a safety checklist of the environment, and then we talk about the available assessment tools, giving examples there. And then relevant to the individual may want to let the healthcare provider know if there's any issues during the session, how they're feeling. And of course, it's important to know that the individual can terminate the session at any time. So it does emulate what an in-person session could be like, but it basically virtualizes everything. So I want to acknowledge that there was significant collaboration between the Heart and Stroke Foundation. That's the website there, www.heartandstroke.ca. And then on the top right of that website, it'll be under For Professionals. And then you'll see it under the Cardiovascular Toolkit. And then again, the CCPR, of which I'm involved. And this also worked with the Core Health Ontario, which had laid a lot of the framework initially. So I'll take this moment just to plug our conference the CCPR is hosting. It's a virtual conference. It's just over a month away. And you can see there, if you look it up under cacpr.ca, that's what we're hosting in Canada. It's 2 days over a week apart. So thank you for allowing me to share this toolkit, and you can contact me through email or through the chat box here. Thank you.
Okay, thank you so much, Colin. And just a reminder to everyone that the ICCPR website provides lots of links to different conferences, including CACPR. So I think it's my turn to speak now, and I'm managing a few screens, so please excuse me if the share doesn't quite come off the way I anticipated. Okay, so we've been listening to some fantastic speakers who are excellent clinicians, leaders of programs, about how they're managing during the COVID pandemic. And it's been very exciting to listen to these. For myself, I'm going to be talking now about improving uptake to virtual programs, because one of the problems that we face is we can build it, but people may not necessarily come. Oh, goodness me. So I have a little hitch. Excuse me. And my little hitch is that I appear to be on the last slide. So excuse me. So what we know about cardiac rehab, and every person on this call who are fantastic clinicians would know this. If you look on the figure on the left-hand side, you'll see that deaths decrease with the number of cardiac rehab sessions that are attended. So effective programs require a minimum dose. So patients should participate in as many sessions as they could possibly do. But of course, we face a problem now. And you've seen this cartoon as shown by Marta previously, that we weren't prepared. We expected that we would have to do some digital transformation, but we didn't think it would happen so quickly. For us in Australia, one of the difficulties that we are facing is that some of our programs closed, and they closed for 6 months. And now we're starting to get feedback that maybe our programs don't need to open, because people are looking at our stats and saying, look, it's not making any difference, nothing particularly happened. So we have quite a fight on our hands to justify the reopening of programs. One of the ways we can do that, of course, is that if we continue to provide cardiac rehab virtually while our physical programs are closed, then we can establish that we do indeed make a difference. And one of the things we also know now is these were the possible coronavirus wave scenarios that were presented to us in 2020. But we all know now that these waves are varying, and they're clearly going to continue straight through to 2022. So however we do cardiac rehab now is going to have to change for some time. Things are not going to go back to completely normal, as our various speakers have discussed. So my role is to talk about improving uptake of cardiac rehab. And I would like to say, importantly, it's so much more than just saying whether patients are motivated or scared, as our previous speakers have pointed out. The model that I've found very helpful to promote uptake is the socio-ecological model. But I want to point out that we indeed have more questions than answers at the moment. So at the public policy level, it's how our funding is provided for telehealth is really important. So in Australia, there's been a big shift so that our Medicare or insurance item numbers are now being provided for general practitioners for telehealth and for cardiac rehab. And that's absolutely vital. We also need to have stories and resources for virtual cardiac rehab, and we have to have staff training that includes virtual delivery, and this now needs to happen from now on for all of our programs. And our associations need to provide guidelines, much as Colin has just pointed out. Important, the final upshot is that virtual cardiac rehab is considered a quality option and not second class. While it's considered second class, we tend to have a self-fulfilling prophecy that patients don't want to come, staff don't really want to deliver it, people think it's not so good. We really should evaluate that. And it should be funded and integrated into normal routine care. In terms of cardiac rehab associations supporting the development of virtual cardiac rehab guidelines and staff training, you can see that ICCPR website provides a lot of COVID resources and backup resources. For instance, our Australian Cardiac Rehab Association also has educational resources that are free and on the web. But I'm going to be referring in the bottom line to our New South Wales, our Australian state guidelines for telehealth for procedures. So one of the questions you need to ask yourself is, how are your associations supporting the development of virtual cardiac rehab guidelines and workforce skills? And if you don't currently have the time and the money because you're focusing on COVID, then use other people's resources and skills. And that's why many of the presenters have referred to theirs today. At the community level, one of the most important things is that we can have fast, cheap internet and virtual platforms, such as the ones we're using today. And that outside of those sessions, that our patients can access videos and booklets 24/7 when they're most able to do it. And that virtual sessions attract no extra costs. So this is some examples of cardiac rehab information available online 24/7. If you don't direct your patients to the information, they will find information any way they can, including on YouTube. So why not direct people? The Irish Heart Foundation had some good information, but again, just to remind you that ICCPR has as well. So I encourage you to think about whether your patient and family can find helpful, accurate information online outside of your program and provide that information to patients as inpatients. At the institutional level, one of the things that really helps uptake with virtual cardiac rehab is that the whole team has buy-in, that there's automatic referral and pre-booking for that first telephone call during admission, that there's enough staff, telephone, internet and computers with cameras and headsets and rooms to offer flexible times and options, etc. But always remembering that a landline or a mobile phone call or an email are really good cheap options as well. One of the things about delivering cardiac rehab virtually, it's not as efficient as groups arriving to your cardiac rehab service. So it's really important to have booking systems and virtual platforms, anything that can enable you to deliver group sessions following an initial assessment and graded exercise. So virtual cardiac rehab can be developed to people who might decide to be in groups at home, but it can also be provided in exactly the same way that we are doing today. At the interpersonal level, ICCPR provides a short module on face-to-face introduction and referral to cardiac rehab during admission, and I recommend that. But what is important, we're finding in Australia that a clear, personalised, unambiguous message of the benefits of virtual cardiac rehab needs to be provided. And not one which says that, sorry, you can't do the in-person program. Patient stories of benefit are needed, but also really practical things like clear information on how to log into the virtual cardiac rehab site, what they can expect, and troubleshooting. And so some of our staff in one of the programs I work with are using an iPad to illustrate that to patients and their family at the bedside. One of the lovely stories I've seen, and this one is from Mayo Clinic, is put into local newspapers and local news stories so that patients understand that cardiac rehab still needs to happen and that telehealth is a really good option. So I'm wondering, I encourage you to think about the media and social media and patient stories that you are using to promote your virtual programs. The other thing that's needed is clear processes for virtual sessions for patients and staff. This IT illustration provides that. And the reason that both Abraham and Colin have provided their information in their seminars is because of this problem. And we're all accustomed to it. We ring patients, they decline, they're not there. 3 days later, you've done your 3 or 4 calls to find the patient. So you really need to provide instructions about the process and what will happen. One of the ways to do that is to ensure that people have access to preparing information on how to prepare for their appointment, how to troubleshoot if you can't hear the clinician, if the clinician is late, what to do. So one of our questions is, how have you prepared your patients for their virtual appointment? And one of the ways you need to do that is to encourage people to be patient and to understand that there may be teething issues in the first few calls or videos. Within the person, the patients need a clear understanding of self-led virtual cardiac rehab benefits, that it does indeed make a difference. And what we're finding in our program in Northern Sydney is that health-related quality of life outcomes appear to be equal from our virtual program versus our group programs. But of course, we differ to North American programs. Our programs are much, much shorter. And encouraging conversations with patients about the benefits outweigh the burden of waiting or having hitches, talking to patients about how they'll manage the Zoom troubleshoot at home. So some of our discussion is always, well, they're older patients, they won't use technology. So in this quite old study now that I did in New South Wales, people who were eligible for cardiac rehab, we in fact found, of course, there were some age differences, but a lot of people use text messages, internet, and email when they may not use FaceTime. And so we have to consider one of the biggest benefits of COVID, and perhaps the only one, is that many of our patients are now have been forced by circumstance to use Zoom for their family, to meet with family, telehealth to meet with their ordinary doctors. So they are far more prepared than they ever used to be. But what's important is to check within your cohort of patients is what technologies are they using? Text, web, WhatsApp, WeChat, do they use trackers? And this is the biggest lesson that I've learnt from COVID, is it's been quite revealing to see what the cardiac rehab team providers are not accustomed to using themselves. So as much as patients have had to learn about technology, so have staff. I've summarized in this table, and I'll just remind you, I'm very happy for you to take a photo, a screenshot, and the slides will be available to you. Thank you very much. And I just remind you that the recordings will be available for everybody. Just stop that share. Okay, so I'm now going to start wrapping up. We were going to have a panel discussion. Gabriella, I think we have just a couple of minutes for that opportunity to occur, and I encourage people where possible to keep posting on Q&A, but I'm going to point out a couple of questions that have arisen that I would like our panel members, if possible, to unmute and reply to. The first one is, have any panel members been involved in open air delivery of programs? Given that that's better ventilation and more able to have spacing.
I can speak a little bit to this.
Yes, please, Colin.
It's Colin here in Canada. I'm not aware of any centers that have transitioned to that kind of setup, because all the centers have gone sort of to the new technologies and all the equipment that exists. If you think back to the start of cardiac rehabilitation in Canada, where in Toronto, they actually had the exercise around a track outdoors. So, you know, we almost have to reinvent the wheel and go back to outdoor rehab in a way because of this pandemic. And it's a good thought. Might be an interesting idea to pursue.
It is indeed a good thought. We have community walking programs where people can space that are led by our Heart Foundation, but I haven't seen our cardiac rehab programs other than encouraging people to walk, to develop outdoor programs. And yes, our program started like that as well. Another question, and I think there's quite a serious question for us to consider. Does anyone have cardiac rehab guidelines for post-COVID patients?
I can answer that. Actually, here in Brazil, we are developing one. We are dealing with this, and I guess we have some rules we are obeying by now, and we are doing well. We are doing well. We are discovering anything new, something new every day, but we are dealing with some rules. Me and my colleagues are trying to develop one. This is our initiative here. We have a guideline who is publishing at our website, showing to our colleagues how to deal with the COVID at the first moment.
Okay, thank you, Prof Gardenghi. We'll look forward to seeing those guidelines, because I think we'll be really snowed under with people who are recovering from COVID, and particularly I think some patients with long COVID and unexpected arrhythmias, cardiomyopathies. So it will be very interesting to see those develop. Another question is related to how are people managing high intensity interval training in a virtual or online way. Have any of you been able to do that? Yeah, I think with HIT, I think the most important thing we're focusing on is getting patients recovered and starting exercise safely. And that HIT would be a little difficult to do unless you had trackers and monitors and those are of course available, but they require a lot more setup.
I can say something as well. This is a good question, and it's a common question because it's such a rapidly evolving area in exercise science, and at least in cardiac rehabilitation. I think a lot of centers that are offering virtual cardiac rehab are recommending it or offering it in some degree. there aren't established recommendations because the concept of virtual cardiac rehabilitation is so new that we may start seeing some guidelines in this area. But you know, it really is dependent on the pathology and the underlying health condition of the patients to determine
Yes, very much so.
what is recommended for that patient. You have to individualize it to the patient, really.
Very much so. And our team has been developing real-time Bluetoothing monitor trackers, physical activity trackers that include heart rate, but it still isn't the same as observing somebody in person. An interesting question to add on to the post-COVID is that, of course, post-COVID, we have a big array of different patients. And one of our questions relates to postpartum COVID patients. If anyone has experienced having postpartum patients in their cardiac rehab who have been COVID affected.
I can also speak about this.
Please.
I had one patient, and it wasn't different from the other ones. She had COVID, and then she came to our rehabilitation center, and it was okay. It wasn't different because of the partum thing. I guess it would not make such difference for them. In my experience, it wasn't.
Yeah, so basically the same principles apply.
Yes.
Yeah, that's fantastic. Okay, now we need to wrap up now. The very first thing I'd like to do is thank our speakers. Of course, Prof Marta Supervia, who's not on board at the moment, but presented such a lovely video talk. Prof Gardenghi, Dr. Babu, Dr. Yeung, and Dr. Heine, thank you so much for your contribution. And it's such a privilege to be here on this panel with such experienced and expert professionals. I would also like to thank Gabriella Gissi and Crystal Altman for helping with organizing and being in the background and managing our technical aspects. I remind everybody that this recording will be available on the ICCPR website, and we'll be sending it out to our registrants. Of course, we always have more people register than are available at the time, particularly during COVID crisis. Thank you so much to everybody, and we'll wrap up now. Thank you.
Thank you.
Thanks.
Bye-bye.